Kia ora everyone, and welcome to our Goodfellow webinar on meningococcal disease in young people, a New Zealand perspective. This webinar is supported by an unrestricted educational grant from GSK. The content was developed by the Goodfellow Unit and our expert speaker. I'm Dr. Louise Kugler, and tonight I'm talking to Professor Nikki Turner. Nikki is a part-time GP in Wellington. She is a professor within the Department of General Practice and Primary Healthcare and is the clinical director of IMAC, the Immunisation Advisory Centre at the University of Auckland. So without further ado, I'll hand over to Nikki. Kia ora, Nikki, and welcome this evening.
Kia ora, and thanks for the very warm welcome, Louise. Thanks, everybody, and welcome to this exciting 1 hour on meningococcal. But I think that I'm grateful that everyone has joined us tonight because as we're all very aware, this is a huge issue for all of us and a concerning issue. So what we're just going to briefly cover tonight is just to touch a bit on the disease and the pathogen, who is at risk, what we do, how can we manage it in primary care, and then looking at prevention options, including vaccines and vaccine strategies. Now, I just want to highlight there the wonderful Charlotte Cleverly-Bisman. Many of you who might have lived through the meningococcal B epidemic we had in back 2002, 2006 will remember Charlotte was severely damaged by meningococcal B disease and lost her 4 limbs. And she's been an amazing New Zealand hero ever since. So I just celebrate Charlotte there. So starting from the disease itself, now I think we're all aware what meningococcal disease is. It's caused by the bacterium Neisseria meningitidis, and the concerning issue for us is it can progress rapidly to very severe disease, and the disease onset is sudden, often very dramatic. It can present in a variety of ways, anywhere from septicemia across to meningitis, but also it can present in unusual ways, and you'll see up the top there is a picture of a septic arthritis. Untreated, it's fatal in about half of cases, and even with treatment, 1 to 2 out of 10 will die. Sequelae are particularly nasty, and up to 1 out of 5 people. You can get hearing loss, you can get seizures, you can get loss of limbs, as Charlotte demonstrated, cognitive problems, motor deficits, visual impairment, a very, very challenging disease for all of us and very frightening. So I think this is a huge list of what sorts of signs and symptoms you can see with meningococcal disease. And I'm sure all of us in primary care are on high alert for this disease. What we do know is that it doesn't always present with the classical meningitis, with the, photophobia, stiff neck, headache. Often it presents more as a septicemic picture where, particularly with young children, they can just come looking crashed out, maybe with a high fever, just generally non-specifically unwell. So you really have to have a very high index of suspicion for this disease. We're all on the lookout for that rash, the non-blanching, sometimes bruising, sometimes petechial rash. But, without a rash, it can definitely still be meningococcal disease. And at times the rash appears very late in the illness. So basically, have a high index of suspicion and treat on suspicion. And of course, as we move into winter, we're all anxious that we don't mix it up with flu and other flu-like illnesses. So the challenging, interesting thing about meningococcal disease is that it's carried in the nasopharynx, and particularly of young adults and teenagers, and anywhere between 15 to 25% of the population of young adults and teenagers will carry this bug in their nasopharynx. And I guess the interesting question for this is how come it's so rare in terms of getting into the individual, but actually so common in carriage. So the bacteria itself is transferred through close contact, such as saliva or droplet spreading. And then it's really trying to look out for these rare cases where it gets beyond the nasopharynx and it invades. And that's what we're worried about. And the absolute reasons for invasion are not always that clear. I think this diagram is really quite interesting to show you just the difference between these encapsulated bacteria, where Neisseria meningitidis tends to be carried in the nasopharynx of young adults, adolescents, and then transferred particularly to young infants and sometimes to the elderly, which is quite a different pattern from strep pneumoniae, which is actually tends to be in young infants and then transferred to the elderly, and the same with Haemophilus influenza. So it's quite a different carriage pattern from others. So moving on, I guess the question therefore is, what does increase the risk of invasive disease? Why does this bug go from the nasopharynx of so many people invasively into just a few? And so there are some risk factors: exposure to tobacco, smoking, and binge drinking, which would be one aspect of young adults. Having another respiratory infection at the same time seems to make it easier to breach the defences. And an important one for New Zealand is housing situation, living in close proximity to others. So this is the issue for young children or adolescents living in crowded houses, boarding schools, halls of residence, long-term institutional care, where the carriage rate, which is traditionally anywhere between 15 and 25%, sometimes in these close contacts can be as high as 100%. And then being in a household or being a close contact of somebody actually carrying the bacterium. And then, of course, there's a range of medical conditions or a range of treatments that might bring down your immune system that make you more likely to be able to catch encapsulated bacteria. And then the strong drivers by age and ethnicity. So when we look at the age and ethnicity drivers, who is at highest risk? Now, the reason for asking this question is because when we come to the vaccination policy, we need to frame around who is at most risk. Now, it's clearly children under 5, particularly Pacifica children and Māori children. The highest burden is under 1. And then there's another age peak in adolescents and young adults. So those are the age groups at highest risk. So that was a little bit about the background of the bug itself. And now just in terms of the epidemiology of the bug, I mean, this is actually quite interesting. Internationally, it varies quite a bit geographically. And I think many of us have been aware for a long time of the sub-Saharan meningitis belt right through sub-Saharan Africa. And for a long time, that was a group A meningitis belt. However, there was a Group A vaccination program introduced in 2010. And since that time, Group A meningitis has dropped dramatically across sub-Saharan Africa. But now what we're seeing is a different serotype arising. And we're beginning to see the rise, particularly in subgroup W, coming through now, not just in sub-Saharan Africa, but in other parts of the world. So, you know, there are different patterns around the world, but essentially it is widespread. Now, what is really interesting, the pattern in New Zealand, for those of us who lived through it, you remember back in the 1990s and early noughties, New Zealand had a strain-specific type of meningococcal B, which has caused that great peak you can see in the graph here. And we did have a strain-specific vaccination program against that particular type. That epidemic dropped away, partially assisted by vaccination, and it was dropping away as well anyway. The vaccination program, I believe, started around 2004. And so we stopped vaccination against that. But you can see the rate of meningococcal disease in general has remained quite high until 2020. And then you see this interesting, quite dramatic drop-off in 2020. Now, the reason for that, and we've seen this phenomenon around the world, it actually started with the lockdown. With the lockdown in New Zealand in late 2020, and followed by the ongoing reduction in transmission with our borders shut down and with reduced travel and more public health measures to keep social distancing, the rates of meningococcal up till this year have remained very low. However, you can pretty well guarantee that's not going to stay. And we would be expecting to see those rates rising again later this year. So this is a bit of a fool's paradise. I'm sure meningococcal disease, like many other respiratory diseases, is going to return this year. Now, importantly, the other aspect of the epidemiology is the age group distribution. And as I'd mentioned before, children, more than 80% of cases are in children up to the age of 20. So the big burden of disease is in children. And of those cases, half of them are in children under 5, with the highest rate by far, as you can see from this graph, being in the children under 1. So it's very clear from this pattern who is at highest risk of meningococcal disease. Now, the next question is what sort of meningococcal disease? Now, there are 5 main serotypes, although interestingly, type X may become predominant, may become more apparent over the next few years. But at the moment, we're focused on 5 different types. And what you can see from this graph is that type B is about half of all meningococcal disease. And then all the others are about the other half. Now, particularly for the children under 2, B is at the highest risk by far. So when we're considering how to manage this disease, you think about half of it being caused by B and about half of it being caused by all the others. And since we've got vaccinations against B and vaccinations against the other 4 type, that matches the epidemiology quite well, about 50-50. So that's my little summary. Currently in New Zealand, the dominant strain is B. Now, the next most dominant strain used to be C, which is in the orange there. But what we have seen up till the lockdown in 2020 was an increasing proportion of W and followed by that Y. Now, the worry about the increasing rate of type W is that it actually has a higher case fatality rate, and it actually goes across the age groups, and it's more likely to present in unusual ways. So sometimes it presents with abdominal pain or more non-specific signs. So W is quite challenging, and it's not as classical as the other types. So what do we do when we see it? Well, firstly, think meningococcal in any concern and any respiratory concern we have. Never forget to think, could this be meningococcal? And if we think there's any likelihood of meningococcal at all, we give antibiotics on suspicion. You know, unlike many other conditions, we do not wait. If we think, I'm worried that this child, this young adult, or even an older adult doesn't look right, could potentially have meningococcal, don't wait. And just go ahead and give antibiotics. Now, our hospital services do ask us, if at all possible, before we give an antibiotic, if we're able to get a bit of blood off, if we could get in a purple top EDTA tube 3 to 5 mils of blood, it's very helpful at the hospital end for diagnostic purposes. However, if it's tricky, not easy to get blood, don't hold up the antibiotics, go ahead and give antibiotics. It's vital, and as we all know, this disease can progress really fast. So treat on suspicion. Nobody's going to give us a hard deal here about using antibiotics. It's more the lack of use of antibiotics that we'll get caught out by. So treatment is one side of it. The other side of it is how to prevent infection. So what we do know is this is the highest risk of infection for a close contact is someone who's had the disease during the last 7 days after the person develops symptoms. You've got a communicability period of about 3 to 4 days without treatment. So not only do we treat the individual, but those around them in close contact with them, we give antibiotics administered to all the close contacts as soon as possible. Apparently the rate of secondary cases in untreated adults is somewhere around 1 in 300. So preventive antibiotics for close contacts is worthwhile. And people often ask, what is a close contact? So this would be considered an unprotected contact who had with the upper respiratory tract or respiratory droplets for a week beforehand, and with the onset up to 24 hours post-treatment of the individual. So just think, could this be a close contact? Remembering this is a notifiable disease, the medical officer of health, the local public health services will be talking to us if and when we have the misfortune to have a meningococcal case, and they will give us advice around who is a close contact and how to treat it. There is advice in the handbook about which antibiotic to use. The general rules currently are that we're using ciprofloxacin for adults over the age of 12 and under the age of 12 or pregnant women. We're using rifampicin or ceftriaxone, but we'll be given advice by the public health services when we do come across these cases. So that's a general run through the disease itself, how we look for it, how we manage it, what it feels like. Now to focus on vaccines. Now it's useful to know a little bit about meningococcal vaccines because it's not as straightforward as some other vaccine topics. So I'll try and keep it as straightforward as I can. It can get a bit complex. Now, the first thing is meningococcal is a disease that progresses very rapidly. So to prevent severe meningococcal requires the presence of antibodies. Many other diseases we can manage with just having cellular immunity, but because meningococcal progresses so fast, we need antibodies on board. So immunization, as we know, generates circulating antibodies, and it's those circulating antibodies that we need to be present when we get invasive meningococcal disease. The downside is that circulating antibodies over time wane. So meningococcal vaccines are not lifelong. They're not like measles containing vaccines. They're not like live attenuated. Individual protection wanes. And even though you might have memory cells, you don't have the time to generate high enough antibodies to prevent the disease. So therefore, whatever vaccination strategy you use, if it's for individual protection and the circulating meningococcal, you need to boost frequently. So the number and the quality of the antibodies, how long they last, will depend on what type of vaccine we use, the type of group we're trying to cover, and the age of the person receiving the vaccine. Now, there are two major groups of vaccines. I think this is the easiest way to follow it through. And firstly, there's the group that covers the conjugates, ACWY and W. Now, traditionally in this group, we used to have polysaccharide vaccines. They were the traditional vaccines, but they don't work very well in children under 2, and they're quite a weak antigen. So what you do, you take the polysaccharide capsule of the organism and you conjugate it, you attach it to another antigen that's much more powerful. And by attaching it to another antigen, you get a much better response, a stronger immune response. So that's what a conjugate is. It's the polysaccharide capsule attached to something else. Now, for example, the two most common conjugates, Nimenrix is attached to a tetanus toxoid conjugate. Menactra is attached to a diphtheria toxoid conjugate. So they drive the effectiveness of the conjugate. Conjugate vaccines are the best thing since sliced cheese. They've been just fantastic. They have excellent safety profiles. They've been used widely in the world now. And the huge advantage of conjugates is they can actually induce sterilizing antibodies. We constantly hear about this with COVID, but in the case of meningococcal conjugates, they have the ability to eradicate the organism for the nasopharynx. So if you use them widely enough, you can actually get herd immunity and prevent carriage in the nasopharynx. Now that requires a widespread national program. Many countries have done this. New Zealand as yet is not doing this. Now, the other big group of vaccines is the vaccine for the serotype B. Now, for a whole lot of complex vaccine reasons, they were unable to make a conjugate to serotype B. So they have in more recent years made this recombinant protein B that's got 4 different types in it, the 4 most common types that make up B. This has taken quite a lot longer to develop. Anyway, they now have this new B available recombinant called Bexsero, which was first licensed in Europe in 2013 and is now licensed quite widely in over 40 countries and is shown to be very effective and have a good safety record. So quite a different type of vaccine from the conjugates, but it covers that important group of B. So this is what it looks like. You can see on one side, you've got a range of conjugates, and on the other side, you've got B. Now, it's quite straightforward with the B because we've only got Bexsero. So if you want B coverage, it's Bexsero. If you want coverage for the other types, those 2 top ones you can see, Menactra and Nimenrix, are quadrivalent conjugates. The third one down, NiceVac-C, is only C alone. And the only time we'd be using that is if we use Menactra, which you can't use under 9 months. So the only case really for using the single C is actually in the national program where they're offering Menactra, not Nimenrix. Whereas Nimenrix we can use from 6 weeks of age. So on the private market, you would not be using NiceVac-C at all. So really, it's the quadrivalent, the 4 types that you want. So here's another way of putting it, that available in New Zealand, the ones in blue are the ones that are funded on the national program, Bexsero and Menactra. and NICEVAC for the kids under 9 months. The below is you can use, oh, sorry, I apologize. The one in orange is the ones that you can use on the national schedule, which is Vexero, Menactra, and NICEVAC-C. The ones above that in blue, all of those are available on the private market. Now, what is quite complicated for us in general practice is that the national program only funds a very narrow group of people for meningococcal vaccines. And it's quite hard for us to remember who is available to have funded vaccine. There's some medical groups that make people at high risk. There are young adults living in close, crowded living conditions, and then you can use them for contacts and you can use them in outbreak situations. The rest of it is private market at this stage. So that's what makes it quite hard. Now, what sort of meningococcal vaccination strategy could you consider? Well, if you're going to offer individual protection, you give a vaccine to an individual, they create high antibody levels and they will get a very good degree of protection. However, antibodies wane every 3 to 5 years. So if you're aiming for individual protection, you really need to revaccinate constantly, usually every 3 years in the little kids and every 5 years or older. So when we're looking at individual protection, it requires repeated vaccination. Now, the better strategy, and the strategy that New Zealand is currently not doing, is really offering it widely to the community. Now, if you do a nationwide program, you would normally start with a program up to the age of 20 or maybe a little older, where you actually reduce the carriage in the nasopharyngeal, in the back of the nasopharynx. By doing that, you then stop the spread around the community. So many countries in the world have used this sort of program. In fact, it's particularly really beautifully seen in sub-Saharan Africa, where they did a large campaign across the ages, removed nasopharyngeal carriage and got fantastic control of meningococcal A. The UK has done it really effectively for meningococcal C, and so has the Netherlands and many other countries. So community immunity requires mass vaccination, and then as the infants are born, they put it on the infant program going through. So that really is the best way to manage meningococcal disease, but that requires a lot of funding. So in New Zealand currently, this has been considered at the pharmac level, and both B and quadrivalent have been considered, and the quadrivalent is considered high priority, and the B vaccine, which is slightly more expensive, medium priority. But at this stage, pharmac hasn't yet chosen to fund a national program. So we're left in this complicated situation currently, where we have vaccines for a few high-risk groups, and the rest is private market availability. So do the vaccines work? Well, now looking at individual protection, you can just eyeball this graph and you can see that generally they're highly effective. So that they're highly effective both with group B disease and the quadrivalent types. So yes, the vaccines work, they work very well. What we do know for the quadrivalents is you need to boost. Now, we're not yet clear with type B whether you need to boost and how often. So we know they work, we just don't know yet how effective and how long group B will protect for. So based on all that background, who do we offer to vaccinate? This makes it quite complicated. If we had a national program, nice and straightforward, but currently it's quite difficult. And the problem I have for meningococcal vaccines is that there is really significant equity problems. Because we don't have a universal program, because we don't have herd immunity, we require individual personal protection. There is a national program, but it's highly targeted for a limited group. It's hard for us in primary care to remember and to offer services to a very highly targeted group. And I suspect the uptake is very low because we're not targeting effectively. We've always known with vaccination programs that targeting is really difficult. It's difficult to remember who you offer it to and to offer it systematically to them all. So the national program, I don't believe we're targeting well. And furthermore, who is at young risk? Who is at highest risk? as young infants, as Pacifica infants, tamariki Māori, people from crowded housing, and people from backgrounds of significant socioeconomic deprivation. Those are exactly the people who cannot afford often private market vaccines. So we've got a real conundrum, and those who are least likely to who are most likely to benefit are least likely to be able to afford private market vaccines. And furthermore, the challenge with the private market is many people are unaware they can access them. Now, I just want to acknowledge Zach Gravatt. Zach Gravatt was a medical student at the University of Auckland. Zach died of meningococcal disease. And it's heartbreaking that his family were frustrated because they did not know that they could have purchased meningococcal vaccine on the private market. So this is a real challenge for us in primary care, is how do we fairly offer these vaccines to the people who need the most, but also to everybody so they are aware they can access these vaccines. So firstly, the fully funded groups, these are quite hard to remember. The first group is people with specific high-risk medical conditions. Now, all of us have got a handful of these people in our general practices, but I sort of defy any of us to just go down that list and remember it all and remember who we should offer a meningococcal vaccine to. So I really want somebody who's much cleverer than me at pulling out these conditions on our IT systems so we can systematically offer them more fairly to our group, because I think we are not systematically offering these to all this group of people. I think most of us are aware that splenectomies need it, and I think we'd be aware of people with significant immune conditions, but more and more we'd be missing, immunosuppression and some of these complement deficiencies in HIV. So it's quite hard to remember this group. Close contacts of meningococcal disease are usually picked up through public health services. The specific high-risk medical conditions are offered the quadrivalent plus meningococcal B. Now, the other group that I think many of us are aware of is those who are in close living quarters. These are adolescents and young adults, anywhere between 30 and 25, who will be or who are currently living in a hostel situation, a university hall of residence, in military barracks or prison. So any young person in those age group who are grouping together, they get funded only the quadrivalent. Now, they should also be offered meningococcal B, Bexsero. Currently, the funding is only the quadrivalent. So that's why things are a little challenging, really. So this is the funding for close living conditions, 1 dose for individuals aged 13 to 25. So for all of us, I just make a plea, think of young adolescents, those who are living in close living conditions could benefit, definitely could benefit from meningococcal vaccine. Some of them are funded. So this is when you get stuck on all of this and you don't understand it. The pharmaceutical schedule, PharmAct, lists exactly who is funded and who is not. So you're not going to remember the finer points of this, just so we know where to go when we're not sure what to look up. So moving on from the funded, who could we be thinking of to offer these vaccines to? Now, as I've highlighted through the epidemiology and earlier on, it's infants and young children, particularly Pacifica, particularly Māori, and those in poor housing and crowded situations, starting with infants, and then thinking of young children under 5, and then the third group are adolescents, particularly adolescents who might be living in close contact with others. So on the meningococcal B side, you have one option, Bexsero. It's currently costing us a bit under $100 to the practice for a single dose, and then we have to put the practice costs on top of that. Bexsero is a 2-dose schedule. And if you start it as infancy, it's 2 dose plus a booster. So that's not cheap for people. So if we're offering B, we also offer the quadrivalent. You have a choice in the quadrivalent. You have Nimenrix or Menactra. Personally, Nimenrix is easier. It's probably got a stronger, more effective adjuvant, and it can be used from 6 weeks of age, whereas Menactra you have to start from 9 months. Nimenrix has got a 2-dose schedule as an infant and then a single dose booster. And Menactra has 2 doses up to the age of 3, and then it's 1 dose. And then for these, you still need to boost every 3 to 5 years. So my suggestion generally to people, if you think about this, is to think about protection for infancy and children under 5, and then protection in the later adolescent years. It's probably the best way to frame it. Otherwise, somebody's going to have to fund buying meningococcal vaccines every 3 to 5 years, all the way through childhood. So moving on to the next slide. This is just a resource from ACWY. It's not a particularly visual poster, but I put this up in my own general practice so that people who are stuck in our waiting room with nothing to do can read down this and look at what's available on the private market that they might want to purchase. The challenge for all of us is how to systematically offer private market vaccines to people who don't know they're available. So I've listed there all the meningococcal vaccines, and there's other vaccines, the chickenpox vaccines, the new shingles vaccines, vaccines for people in close contact, hepatitis A, hepatitis B vaccines. So this is just a list of vaccines available on the private market. And it's not from pharmaceutical company branding. So it's just a list of the vaccines that ACWY would consider are worth and useful for people that are on the private market. So now I'm just going to run through a few examples just to see if we can get our heads around who might be eligible versus who could benefit. So I'm just going to run through a few examples. So you've got Peter, who's 3 years old. He's just been discharged from Starship. He's recovering from meningococcal disease, meningococcal B disease. So should Peter be offered any vaccine? Well, actually, because he's had B, he's eligible for the quadrivalent vaccination against the other strains. So he is eligible for funded vaccine. Penny is Peter's younger sister. Is she eligible? Well, she would have been eligible as a close contact, but now he's fully recovered. It's too late to be considered as a close contact. However, clearly, Peter was in a high-risk group to have got meningococcal disease. I would personally be very keen to ensure that Peter's whānau and those around him are also vaccinated. So I would be keen to offer her and the rest of the whānau private market vaccine. This is a common one for us. Christine's a healthy 8-year-old and her parents wish to protect her against meningococcal disease. Now that's fine. If they understand and they wish to offer protection, that's totally fine, go for it. However, 8 years is not necessarily the peak of disease age. So they can offer it privately purchased, but they need to recognise that protection would wane in about 5 years. So it's not going to get her through all the adolescent years. So they're welcome to purchase it. She's probably not at highest risk. And you might want to suggest that she might benefit more from vaccination in later adolescent years. No harm in giving it to her at the age of 8. It's just the incidence is so much lower at that age. So then you're moving into the adolescent group. Mika is 17. She's moving into university. She's moving into a flat with her 3 friends next year. Now that is not a halls of residence, so she's not eligible, but she's definitely worth offering it to. And I think this is absolutely the sort of adolescent that we should be offering the B and the quadrivalent to. So Reggie is Samoan, 6 months of age, 4 other siblings. To me, this one's a no-brainer. These are the kids that should be offered meningococcal vaccine. Clearly, this is a big household, a lot of young kids in it. There's probably adolescents carrying it in this household. I would love to be able to offer Reggie vaccination. Now, interestingly, Reggie's sibling had meningitis 2 years ago. So Reggie himself is not eligible, but I would be really keen to offer it to him. Now, then you've got this situation. Jamie's 14. She's moving to boarding school next year. She is eligible for funded vaccine, but she's only eligible for the funded quadrivalent. You'd also want to offer her the private market B. So you can see it's all a bit complicated at the moment, but I want to highlight the importance of infants and young children first, and then adolescents second as important groups for meningococcal disease. Now, I've been going on for a long time, so I'm going to rapidly go through the types. I've mentioned there's B. This is a little bit of material on what Bexsero is. It's 4-component. One of the components is actually the outer membrane vesicle that we used back in the meningococcal, the MENS V outbreak in 2004 to 2006. Now, anyone who received that vaccine back then will no longer have protection from that. That was too long ago. They will not have meningococcal protection, but that component is in Bexsero. So that's the Bexsero vaccine. You can use it from 6 weeks of age. It's a 2-dose regime. If you start in infancy, you give a booster. It's very similar to other vaccines given in the thigh in infants or the Delta in older people. Now, there's one challenge with Bexsero, is that it's very reactogenic. So Bexsero, particularly for children under 2, tends to give a fever. Now, what they discovered in the UK is that a lot of kids having fever, not necessarily a problem having a fever, it shows that you get a good immune response, but a lot of kids ended up in hospital being worked up for pyrexia of unknown origin. And so a lot of these kids ended up having unnecessary interventions, lumbar punches, trying to figure out if there was an infection going on. So now they recommend for children under 2 only to use prophylactic paracetamol. You use 3 doses every 6 hours, whether the kid had a fever or not, and start the first dose before the vaccination. This is different from any other vaccine. We don't recommend routine fever control normally at all. The reason for this is just so the kids don't end up with being over-investigated in ED admissions. So just remember for Bexsero, how do you organise ahead of time so that the family have actually given the kid paracetamol before you offer Bexsero? Only for the kids under 2. Other people are welcome to have paracetamol or ibuprofen for discomfort or analgesia. There is no need to treat a fever normally. This is the one exception. I've mentioned the conjugates, so I think we'll move on to the conclusion so we have time for a few questions if everybody's still with me. So firstly, I think we're all very aware this is a high-risk condition, need to be alert. It's potentially increasing internationally, although we've had a down period with COVID and lockdowns, we're expecting it to see come back. There's a particularly worry and increase in type W around the world, which is a nasty, highly lethal type. 2 different types of vaccines. You've got the conjugates, and then you've got the recombinant B. We have a national immunisation program, but it's only funded for specific high-risk groups, which are quite difficult for us in general practice to remember, to search, and to systematically offer services to. The current program does not offer herd immunity, it's only personal protection. The private market, those at high risk are infants, children under 5, and adolescents, particularly Pacific and Māori, and think housing conditions, big families, crowded living conditions, and poor social conditions. This is a nasty disease. Those are the children who benefit most from it. Now, when you're stuck, where do you go? The 2 key resources are the immunisation handbook that you can see there that is now fully online. If you want to know when and how and who to give vaccine to, hopefully we've got all the material relatively clear in the immunisation handbook. When you're a little unclear about funding, then there's the online pharmaceutical schedule. I don't know if anyone uses it much, but it's quite useful to plug in meningococcal vaccines and it will tell you who's funded and who's not. Alongside that, there is a range of IMAC resources, hopefully to help you through this issue, which can sometimes be very confusing for people. So we've got a range of resources available as well. And I just finished with my co-author. This is Eric. Eric helped me with this presentation. He wasn't very good, but he really likes graphics jumping up and down. So I want to acknowledge Eric and all the help he gave me with this presentation. So kia ora koutou, thank you so much for coping with all of that. It's a lot of material and I hope there's some questions and comments to follow. Kia ora, and I'll end the slideshow.
Thank you, Nikki, for once again a fantastic presentation. And as you go through, questions come up and then you answer them. So thank you for being so onto it. I think the take-home point for me tonight was high index of suspicion. And as you mentioned, we're heading into the flu season and we know that our immunity has waned in New Zealand as we've been at home. And I understand we have had a case in measles in Christchurch last week. So other infectious diseases will be coming. I wondered if we could start with some questions. We've had lots of questions about students and boarding houses, and that one's quite close to my heart. Babies who were born around 2004 to 2006 may or may not have had the meningococcal B vaccine offered to them. And you did comment that immunity wanes and we're not quite sure when to boost. So I suppose those students now will be teenagers going perhaps into boarding houses. So should we routinely be offering those students the meningococcal B as well?
Yes, we should definitely be routinely offering it to them. The Men's B program 2004-2006, antibody levels will absolutely have waned. So you cannot guarantee any protection from that at all. So regardless of their vaccination history, I think any adolescents going into halls of residence, it's not funded Bexsero, but they should be offered it. It's a 2-dose regime too. So, you know, it is more than $100 a pop. Remember, it's 2-dose. I'm still trying to get the second dose into my lad. He's wriggling and running. He keeps reminding me that he was the only boy that had to have HPV vaccine way back. So now he's running from Bexsero, but they need a 2-dose regime. And also those who are going maybe not into halls of residence, but also into student flats, you know, I would offer them vaccination. You know what adolescents get up to. They're in close contact with each other. There's a fair bit of sharing of saliva. A lot of them are carrying it in the nasopharynx. There's quite a lot of get-together bits. Definitely offer it.
There's another question about teens heading off to the halls, and if they've had a funded Menectra in the last, say, 5 years, is it then worth giving them a privately funded Menectra? Is it worth giving them a funded one if they're around that 5-year mark?
Yeah, the general rule of thumb is you'll be getting waning immunity by 5 years. So single dose, give them another dose, yeah. And if they're in halls of residence, at least they'll get it funded.
And do you know of any work, Nikki, that's being done with either the universities, the boarding houses, or the halls to raise their awareness of this problem?
Yeah, so before the COVID lockdown, the Ministry of Health actually did have a promotional program for a while that they were working with all these institutions, including the prisons as well, to remind them of the importance and the fact that, you know, at least the Menectra is funded. But that's sort of fallen away through the COVID era. So I think, you know, I know we're all pretty worn out by COVID, and I'm delighted I haven't mentioned it very much. But, you know, we've got to start picking up around all these other things now. Meningococcal coming back. So, you know, there has been very little awareness of this in the last couple of years. So, yeah, all of us, you know, raise it to high awareness. Just think of those adolescents heading off to university now. It's been a pretty crazy time for the last 2 years. Good time to start protecting them.
I suppose it always brings up, you mentioned equity quite a bit. And I always like to think if money wasn't an issue, what would we do? And I think you've hinted to a population approach. Would that be your recommendation for New Zealand?
It would absolutely be my recommendation for New Zealand. I mean, I'm not an economist, you know, I want to stop meningococcal disease in New Zealanders. You know, we're all terrified of this disease for good reason. So what I would recommend is that for the quadrivalent anyway, you would start with a universal program probably from infancy right through to 20. You'd do a mass vaccination for everybody. And in doing so, you'd eradicate at least 4 types from the nasopharynx. And then once you've done the mass vaccination program, then you tend to do vaccination in the infant program and potentially a vaccination in young adults. So like the Dutch do infant program in 11-year-olds going forward. Once you've got good control and you've got less spread, then you can just embed it in the national vaccination program. And I think the Dutch are probably the best example in the world. Meningococcal B, I really think we need at least an infant program for the meningococcal B. You can see there are incredibly high rates of B in our young infants and our kids under 5. So that would require a primary course in infancy of 2, plus a dose in toddlers. And there could be an argument about introducing B into adolescents as well. But I think that's what I'd start from. And there's countries in the world who've done it really well.
And I suppose it becomes a health economics thing, but is the feeling that actually it's cost effective in the long run?
It depends how you cut cost effectiveness. That's really a question for Pharmac. I'd argue that it is. I think, you know, it really depends how you put all the different elements into the cost effective model. I mean, it is a rare disease, so I can appreciate why Pharmac hasn't rushed in to fund it, because it is, invasive disease is very rare. But it hits young people, it hits healthy people, and it's hugely savage. I mean, you look at that picture of Charlotte, that amazing lass with no limbs, and she's making a fantastic life, but it's not easy. And, you know, she's got to carry that through her whole life. So it is really about balancing out where you put your health dollar, really. I think the other thing that makes me frustrated is the inverse care law, that this disease is way more prevalent in kids who are in crowded conditions and kids in lower deprivation areas. So once again, it's unfair, basically.
Yeah. You've mentioned the private market discussion. Sometimes that's a tricky one for us to have because we know there is such big equity issues, and for some family it's just not possible. Do you have any tips or tricks to bring that conversation into our practice rooms?
Yeah, it's really, really hard because firstly, we're gatekeeping. We're assuming people can't afford it. And I'm always surprised when young families that say, you never offered it to me, I'd find a way. So I don't know the answer, except I'm not doing it well either. But I think even from the 6-week check, we should be thinking, are we offering meningococcal consistently to everybody? And then in our adolescents, are we offering meningococcal consistently to everybody? I think that's the only fair way to do it, is to offer it consistently to everybody. And if people can't afford it, then go, have we got practice means to get around this? Have we got SIA funding? Are there other ways of doing it? But I'm failing, and so I'm sure many of you are as well, to do this consistently, both in infancy and then for adolescence onwards. So yeah, we've got to find a better way to do it. In the meantime, the other problem is we're not getting the highly targeted ones either. And, I think it's the way we're coding and not pulling the codes off our practice management systems to see if we've searched for these high-risk kids and adults as well. So yeah, I think, it's hard one, meningococcal, to fit in with our systems, but it's really important we think about it.
Yeah, absolutely. And I think your resource, the poster, having that both in your consult room and perhaps in your waiting room and in your nurse's room is a good reminder. So thank you for pointing us to that resource.
I'm afraid it's not very visual. I wish we had a more visual one, but there's so many to put on it that at least people can read it.
We do have a couple of questions about swapping brands when boosting. So perhaps someone's had a Menactra recommended to them and now they're due for a booster. Can we then swap to Nimrex?
Nimenrix. I'm never sure how to pronounce it. I presume it's Nimen because of the meningococcal in it. Nimenrix is actually probably the better vaccine. It's got a conjugate that actually drives it a bit better. So many people have assumed that you have to always use Menactra because that's the funded one. But, Pharmac funds the vaccine they get the best deal for. They don't necessarily fund the best one. So you can use either. You can interchange them. But I would suggest if you were starting, then go for Nimenrix would be my personal opinion, particularly because you can start in infancy. It's funded from 2 months, but you can give it from 6 weeks.
Great.
Sorry, funded. Sorry, it's authorised from 2 months. Sorry, but you can give it from 6 weeks.
And then we have touched on the Bixera booster. So if we could sort of put a line in the sand so that we start thinking about that. Are we thinking 5 years, 10 years to offer a booster? Do you have is there any data at all?
I'm not sure yet, probably 5 years. But once again, if you cover your infancy and then cover your adolescence, for the moment you're covered because it's a 2-dose regime. So we're reasonably covered at the moment. Maybe I'll come back in a year or two and we'll see what it's looking like. But, once again, it's going to wane. So it'll be a few years and you can think of a booster. There's no safety concerns, I would think, about boosting.
Great. And then there's a couple of questions about prevention in very early childhood or in our infants. A comment about breastfeeding. Do we know if breastfeeding is protective?
Well, it can't. No, it's not entirely. I would have to look that answer up. I can't tell you, but I do know that breastfed infants do get meningococcal disease. So the answer is no. And I suspect why is because the infant would need high antibody levels transferred from the mother. And it's pretty unlikely that a mother would have high enough antibody levels to transfer them in utero to the fetus to protect the infant, or that enough would come through the breast milk. So off the top of my head, I think breastfeeding, great though it is and important though it is, would not be highly protective.
Great, thank you, Nikki. And then for those families who do have the ability to purchase on the private market, what would the optimal regime be for these infants?
Yeah, so I would suggest a primary course, both of Bixera and a quadrivalent for infancy, which is a 2-dose primary. It's a lot of vaccines, 2-dose primary course of both, followed by a booster in the second year of life. And then that would probably get them through to the age of 3 or 4 when the incidence is dropping off. And then I would suggest you get to mid-adolescence. And if you're probably wait till mid-late adolescence till you're thinking about moving away, if you're going to university or you know doing something else as a young person. And then I'd revaccinate at that point with both the quadrivalent and the Bexsero. That would be my advice. It's not absolute. It's based on individual protection. The ideal will be a national program.
Yes, yes. And then a question about the timing of Bexsero and Menactra. So can we give them together? And then you mentioned 2 doses. How far apart are those doses, please, Nikki?
So they tend to be 8 weeks apart, and yes, you can give them together. You know, Bexsero is reactogenic, and we're also offering all the other infant schedule vaccines. So it's a bit of jiggling and mixing and matching for kids. Now, there's a lot of vaccines, but certainly motivated parents are keen. Remembering too, now a lot of parents are sending their infants to early childcare centres very young, you know, so there's a lot of mixing and matching going on. So, you know, thoughtful parents are often very prepared to walk through. There's no problem with giving them all together. Just remember Bexsero and fevers in young kids.
Great. And I was just wondering, you know, my teaching for giving paracetamol around vaccinations was don't do it because it can dampen the immune response. So is there any concern about that? So, you know, in the very little ones, we give a prophylactic dose, but should really be waiting and have quite a miserable child before we give paracetamol, worrying about that immune response.
Yeah, so there was some data suggesting that paracetamol for some vaccines might blunt the immunogenicity response. However, childhood vaccines on the whole are so vigorous that even with a little bit of a blunting, they're really effective. So my rule of thumb is antipyretic, only Bexsero. For the other vaccines, analgesia for miserable kids. We've all been mums and dads. We know what miserable kids are like. Use it for analgesia and discomfort. And that's a great role for it. But you don't necessarily have to use paracetamol for an antipyretic. There's nothing wrong with fever alone. There is something wrong with a miserable, grumpy kid. And that's where it's useful. So that's my advice is leaving Bexsero aside, you use paracetamol for discomfort and misery.
Great. Okay. Thank you for clarifying that one. Just a question about when an individual has had meningitis, perhaps a viral meningitis, are they then eligible for a funded vaccination?
No, only if they've had one of the other types of meningococcal meningitis. So no, unfortunately, it doesn't go across to other meningitises.
Okay, great. Thank you for that. And then just a question about recommendations for the household and family should one child be a suspected case. I think we touched on that in the presentation, but it's quite a valid point. I wonder if we can just clarify that one.
So close contacts are at higher risk. And I think, as I said, you know, an adult of a close contact has got a 1 in 300 risk of catching meningococcal disease, which is actually really high. So close contacts should be given antibiotics. And they should be eligible for vaccine as well. Get advice from the local medical office of health. You know, this is a notifiable disease. They should be in touch with us anyway, but get advice and try and get antibiotics into all close contacts as soon as you can, preferably within 24 hours, but as soon as you can. And then once somebody's treated, the bug should be out of the nasopharynx within 24 hours. So they're really, they're safe a day later after you start treating them.
Great. Okay. Thank you, Nikki. Now, actually, a couple more paracetamol questions have come up and they seem quite relevant. So I wonder if we can go backwards and address those. So there is a concern about paracetamol in the infant under the age of 1 and perhaps an association with asthma. I know that study isn't out completely yet. So do we need to consider that or be worried about that?
Yeah, it's a bit of a trade-off, isn't it? I mean, it's not proven yet is the only thing I can say. It hasn't been shown. It's just a suggestion it may be a problem. I don't know if that is about frequent use of paracetamol or occasional use of paracetamol. So in this case, we're talking about 3 doses. So I can't really answer it, except I know we're all watching it closely, particularly knowing New Zealand's part of the study. But in the meantime, I would hope and expect that 3 doses of paracetamol is not a large amount for a child. And I think very few of us would get through infancy without using it occasionally. Obviously, we're all trying to use it less than we're used to. But on the other side, a miserable child or a child who gets investigated for a fever is not a good look. So I think we've got to be slightly pragmatic on this one. If it suddenly shows there's a very strong link, then we're going to have to change your advice. But I'd be surprised if you suddenly throw up a very strong link. I suspect we're more likely to see there's a potential possible weak link. Yeah.
And the concern, I think, is also with non-steroidals. So swapping over to Brufen may not be an answer.
No, but I understand Brufen's in that trial as well.
That's right.
So, you know, I mean, nothing's quite straightforward in life, is it? So I think we have to make the best call we can for the moment, balancing all these different issues. And, you know, it's disappointing being so reactogenic, but that's what we've got. It is the only B we've got.
Great. We've just got a couple more questions before we wrap up for this evening. So just a question around the timing of a pneumococcal vaccine with a meningococcal vaccine. What's the ideal situation here?
No, you can give them together, I believe. I think there's one quirk to that, and I might just have to get back to you on it. I think there's a quirk I've forgotten. So can you hold that question for me afterwards, and I will come back to you. I think there's one little exception. I've forgotten what it is. I think it's around Menactra, and I've completely forgotten.
Thank you, Nikki. So question around healthcare workers. So we're all here and we're all healthcare workers. Are we at increased risk of meningococcal disease, and should we be considering vaccinating ourselves?
Yeah, really good question, eh? I mean, some of us have got complement deficiencies and unusual issues that make us at slightly higher risk. So leaving aside that small group of us, I don't think we're at particularly higher risk than others. This is close contact. I think the other interesting thing for all of us now, and we've learned from COVID, is we should be wearing masks. And I think wearing masks and wearing N95s will be way more protective. So I think for us, rather than constantly vaccinating through adult years for a essentially extremely rare disease, we should be more focused on N95s and protection that we should have been using anyway for years in general practice. We've just been a bit slow to get there. So I think some of the spin-offs of what we've learned, you know, I'd be saying now we should be wearing N95s religiously, regularly going forward. And I know it's a bit depressing for our jobs, but I think that's the way it has to be. And that will certainly considerably reduce our risk of catching something like meningococcal disease. It's pretty rare anyway for a healthcare professional. It does happen occasionally, but it's very rare.
Great. Thank you, Nikki. And then just a question about supply. So we are coming, you know, we're in a pandemic and some things are in short supply. Do we have any concerns about vaccinations?
Yeah, good question. Not that I'm aware of. At this stage, I haven't heard there's any supply problems so far.
Great. Well, Nikki, I'd like to thank you for a fantastic talk tonight. It's always a pleasure having you with us and involved in our webinars and podcasts. You're a great resource, and so I thank you for your time. We will have this presentation up on our website, so please revisit it, and tied to it is a podcast on meningococcal disease that Nikki and I have done as well. So I encourage you to have a listen to that. Our next webinar is next week on April the 5th on atrial fibrillation, reducing the risk. So thank you for joining us this evening. Thank you, Nikki, and have a great evening, everybody.
Kia ora tātou.